thank you everyone for your attention. This is a large topic to try to cover in a short period of time, but what I would like to do is try to give you a framework from which to think about these cases and to make it a little bit easier for you to work through them when you see these patients. So what we will cover, I have no disclosures. What we plan to cover is to give you an overview of glomerular injury, the patterns of injury and how these affect the clinical presentation. And then we'll discuss nephrotic states and nephritic states. So beginning with glomerular injury, I think it's very important to look back at the overall structure of the kidney. So we have somewhere between 500,000 and 1 million nephrons in each kidney. And if we look at the glomerulus in itself in greater detail, just to take you through it step by step. So we begin with the blood vessels. These are the capillary loops within the glomerulus, lined by the fenestrated endothelium here in this beige color, which then is overlaid by the glomerular basement membrane here in orange. The glomerular basement membrane is then covered by the podocytes with their blue interdigitating foot processes, seen here, which entirely cover the glomerular basement membrane. And these lie on the urinary side of the basement membrane. This here is the urinary space where the podocytes lie, lined again by the parietal epithelial cells and then draining to the tubules. So I would ask you to keep this structure in mind as we talk about the different types of proteinuric and hematuric states. So again, this is a normal glomerulus, and you can see nice wide open capillary loops with this thin ribbon-like basement membrane and not too many cells. And on an ultrastructural level, this is what we see on electron microscopy. You see the dark glomerular basement membrane here. This is the blood side with the fenestrated endothelial cells. And highlighted here are the healthy podocyte foot processes, which have the little slit diaphragms down at the basis, which form the filtration barrier within the glomerulus. So when we see patients with glomerular disease, the pattern of injury is determined by where it is targeted by that particular injury. So if you have a condition where the podocytes are actually injured, that the injury is on this particular side of the glomerular basement membrane on the urinary side, and you see proteinuria and nephrotic syndrome with heavy proteinuria. If the injury is on the endothelial cell side, it's a much more inflammatory presentation, and patients present with nephritic syndrome. So clinically, we see these are very different. Those patients that present with nephrotic syndrome have a lot of edema. Their blood pressure and JVP tend to be on the normal side. They obviously have heavy proteinuria by definition. They may or may not have hematuria. Red cell casts tend to be absent, and there's hypoalbuminemia. In contrast, those patients with nephritic syndrome do have some edema, but it is less. And they tend to be hypertensive and more volume expanded with elevated JVP. The level of proteinuria is less, but they have more marked hematuria. And some patients with nephritic syndrome will have red cell casts. The albumin may be a little decreased, but not to the same extent as we see in nephrotic syndrome. So to focus, first of all, on the nephrotic syndromes and the proteinuric states. So I like to divide them into the primary nephrotic syndromes, which are those where there's the injury is directly affecting the podocytes, versus pretty much everything else, where you can have non-nephrotic proteinuria or proteinuria that reaches the level of nephrotic range, but you do not see nephrotic syndrome. So the primary podocyte conditions are minimal change disease, primary FSGS, membranous nephropathy, amyloidosis, and collapsing glomerulopathy are the main ones that can present with the nephrotic syndrome. And then non-nephrotic proteinuria, nephrotic range proteinuria, secondary FSGS, obviously from many causes, secondary glomerular diseases such as lupus. Diabetic nephropathy is probably the commonest one that we see. In my work, we see a lot of transplant glomerulopathy. And the primary vascular diseases and tubulointerstitial diseases can also cause proteinuria. This tends to be lower, and we talk about this as tubular proteinuria, which is really around the 1 to 1.5 gram range, so tends not to reach a nephrotic range. So comparing nephrotic syndrome with non-nephrotic proteinuria, again, the proteinuria is heavier in those patients that have nephrotic syndrome, but it tends to be a more sudden onset of proteinuria and renal dysfunction. These patients obviously have edema and hypoalbuminemia with a relatively bland urinary sediment because the endothelial side of the glomerular basement membrane is intact, so you tend not to see red cells and inflammation. In non-nephrotic proteinuria, obviously the proteinuria is lower to begin with, but then progresses, and this tends to be a more slowly progressive condition. Because there is compensation with differing degrees of involvement with different glomeruli, you tend not to see edema, and the albumin tends to be maintained. And obviously there can be a variable sediment depending on what the underlying cause is. So to evaluate patients with proteinuria or nephrotic syndrome, obviously we start with the history and physical exam. You need to do a detailed history in terms of family, social history, drug exposure. And the things that you were thinking about are infections and age-appropriate malignancies, and in particular hematological malignancies, because there are a number of light chain associated diseases, and membranous nephropathy can all be associated with hematological abnormalities. You obviously want to look at the urine. A 24-hour urine collection is best to accurately measure the proteinuria. Spot samples can be variable. A renal ultrasound is helpful if you're thinking about primary versus secondary, something like secondary FSGS. Immunoglobulins, SPEP, light chains, and UPEP, again, if you want to think about amyloidosis or other light chain associated diseases. Antiphospholipase A2 receptor antibody is very specific for membranous nephropathy, so this is a very useful test. We also look at HIV and hepatitis screen. We do an autoimmune screen. But most patients with nephrotic syndrome will require renal biopsy for diagnosis and prognostic information. So let's do a case to apply some of the things that we've talked about. So this is a 23-year-old woman who presents with a 2-week history of lower limb edema, weight gain, and reduced urine output. She really has no past medical history of note. On exam, her blood pressure is 100/60, her heart rate is 84, she has no elevated JVP, her lungs are clear, and she has 3+ upper and lower limb edema. Her urine shows 1+ blood, but 3+ protein, and the microscopy shows a couple of red cells and occasional granular casts. Her creatinine is normal at 0.9, and her albumin is 2.8. Her spot urine protein to creatinine ratio is 7.5 grams. So which of the following is correct? The renal biopsy will show immunofluorescence for IgA. On light microscopy, spikes will be seen on the glomerular basement membrane. Antiphospholipase A2 receptor antibody is likely to be positive. Electron microscopy will show patchy foot process effacement, or this presentation may be caused by NSAID use. I'll give you a moment to give some answers. Okay, great. We have a lot of answers and some variation in opinion, which is interesting. I'm glad that this has generated a little bit of thought and discussion. So the correct answer actually is that this presentation may be caused by NSAID use. So let's work through the case a little bit. So renal biopsy showing immunofluorescence for IgA. This is in keeping with IgA nephropathy. But this is a young woman with a 2-week history of edema. She has 3+ proteinuria, upper and lower limb edema, 7.5 grams of proteinuria. This is really a classic nephrotic syndrome. IgA can have nephrotic range proteinuria, but it tends not to present with this very abrupt onset of edema and heavy proteinuria. So this doesn't really fit with IgA nephropathy. So spikes in the glomerular basement membrane are associated with membranous nephropathy. And again, that tends to be a more indolent onset, and patients usually have an increased creatinine if they have this degree of proteinuria. So it doesn't fit that well with this condition. Similarly, antiphospholipase A2 receptor antibody is highly specific for primary membranous nephropathy. So that does not fit for this particular case presentation. If we talk about patchy foot process effacement on electron microscopy, that suggests a secondary glomerular process. So when we talk about primary podocytopathies, so these are the conditions that present with nephrotic syndrome, primary FSGS, minimal change, membranous. These cause diffuse foot process effacement. So all of the foot process and all of the glomeruli are involved. So patchy foot process effacement wouldn't be seen in this particular type of condition. So to those of you who chose the NSAIDs, you were correct. So this presentation is most consistent with minimal change disease, which can rarely be caused by NSAID use. So it's a tricky question, but hopefully illustrated some helpful points. Okay, so moving on to the nephritic syndromes. So again, these can present with a spectrum across the clinical presentation from rapidly progressive glomerulonephritis, or RPGN. This is really a clinical term which refers to obviously sudden onset renal failure, but we typically see crescents on the renal biopsy. Patients can also present with acute nephritis or asymptomatic hematuria. And so there is hematuria in all of these conditions. The more aggressive forms tend to have an active sediment. There is some degree of proteinuria, but those with RPGN tend to present with rapid onset and azotemia, or worsening renal failure, whereas those with acute nephritis also can have relatively sudden onset, but not quite as quick as what you see in the RPGNs. Those with asymptomatic hematuria tend not to have hypertension or edema or oliguria, but these conditions are more common in the more aggressive forms of nephritic syndrome. So let's get into a case of nephritic syndrome. So there's a 64-year-old male who presents with a 1-week history of low-grade fevers, fatigue, and dyspnea. Over the last few days, he has noticed a rash. He has increasing lower limb edema and dark colored urine. In his past medical history, he has hypertension and HFrEF with an ICD in place. On exam, he's hypertensive at 170/90. His heart rate is 72. He has an elevated JVP, basal crackles, 1+ lower limb edema, and a prominent vasculitic appearing rash on his lower limbs. His creatinine is 2.5 from a baseline of 1.3. And on his UA, he has 3+ blood and 2+ protein with 15 to 20 red cells per high powered field. His microalbumin to creatinine ratio is 1.2 grams. And on his serological workup, his C3 is low at 40 and his C4 is also low at 5. His ANA is negative. So for this particular patient with a short history of low-grade fevers, acute kidney injury, dark-colored urine, and hematuria, which of the following is correct? This patient needs a CT chest to look for pulmonary hemorrhage. Renal biopsy may show negative immunofluorescence. The presentation may be associated with Staph aureus bacteremia, or this patient should be treated with empiric steroids. And again, I'll give you a little time to answer the question. Okay, great. We have quite a few answers. So let's take a look. So the correct answer is that this presentation may be associated with Staph aureus bacteremia. So again, let's work through this case a little. So those of you who are thinking of pulmonary hemorrhage, obviously you're thinking of the pulmonary renal syndromes. The important clue in this particular case is that ANCA vasculitis and anti-GBM disease do not cause hypocomplementemia. Other than that, there could be some features that are suggestive of it, but that essentially rules out these two conditions. Negative immunofluorescence on a renal biopsy where you have this type of active nephritis suggests post-immune glomerulonephritis, which is essentially the pathological pattern that we see in ANCA vasculitis. So again, because there is hypocomplementemia, this particular answer is not correct. So for the option that this patient should be treated with empiric steroids, this particular presentation raises concern for staphylococcal associated glomerulonephritis, and that should initially be evaluated and treated before you would think about immunosuppression, because we'll talk about this a little more, but this is associated with active infection as opposed to post-infectious GN, where the infection has resolved and you're seeing immune complex deposition in the kidneys, and quieting the immune response with steroids may be helpful in that condition. Here you want to treat the infection. Okay, so to think about the nephritic syndromes because there's a large range of them and they're more complex. So broadly, we like to divide them into the immune complex deposition diseases, post-immune GN, and anti-GBM disease. This is a pathological way of thinking about them, what you see on the biopsy. So under the immune complex deposition diseases, you have IgA nephropathy, all of the infection-associated glomerular diseases, things like lupus nephritis, and membranoproliferative GN. Membranoproliferative GN obviously brings in a huge number of conditions, and this is simply a pattern of injury that you see on biopsy rather than a diagnosis. As I said, post-immune GN is associated with ANCA-associated vasculitis, where there's nothing on the immunofluorescence, even though you have a crescentic GN on the biopsy. And then anti-GBM disease is also unique because you see linear IgG staining along the glomerular basement membrane, so quite a distinct pattern that indicates the presence of anti-GBM disease. So this particular case comes in under the infection-associated GN, which takes in post-infectious and staphylococcal-associated GN. So to talk briefly about staphylococcal-associated GN, because I think this is one that's not discussed quite as widely, patients tend to present with AKI and nephritic syndrome, and it's concurrent with the infection, frequently of skin and soft tissue, but patients also have infection of indwelling hardware and cardiac infection. They have a vasculitic rash. Hypocomplementemia is often present, but not always. And the biopsy shows a proliferative glomerulonephritis, so a lot of cells, a lot of activity, and there is a lot of IgA deposition on the immunofluorescence along with C3. And this is what we see on immunofluorescence, coarse, granular, both mesangial and capillary wall staining for IgA. The management is treatment of the underlying infection, so you treat with antibiotics, but the prognosis is relatively poor. Patients tend not to do well with this condition. If you contrast it with post-infectious GN is classically associated with streptococcal infections, tends to occur after the infection is resolved, and you see IgG as opposed to IgA on the biopsy, so little different. To touch briefly on membranoproliferative GN, all I would say to you is that this is a condition that occurs due to chronic damage on the endothelial side of the glomerular basement membrane. And this can arise either due to immune complexes or due to dysregulation of complement. This isn't a diagnosis. This just tells you a pattern of injury. And for those of you who are interested, I would encourage you to read Sanjeev Sethi's paper on the classification from the New England in 2012. It lays it out very nicely. So when you're working up the nephritic syndrome, again, history, physical exam, thinking about drug exposures and age-appropriate malignancies, this is very similar to your workup for nephrotic syndrome, apart from checking ANCA, anti-GBM disease. The complement, you may have conditions where complement will be low, but again, many of these patients will require renal biopsy for definitive diagnosis. So just to give you a couple of take-home points. So again, to emphasize, the nephrotic syndromes arise due to injury on the podocyte side of the glomerular basement membrane, and we call this subepithelial deposits because the podocytes are part of the epithelium. The nephritic syndromes arise due to injury on the endothelial side of the glomerular basement membrane. Nephrotic range proteinuria can be due to primary nephrotic syndromes or one of those secondary causes of heavy proteinuria. The nephritic syndromes can arise due to immune complex mediated glomerulonephritides, post-immune GN or anti-GBM disease. And then we didn't get into asymptomatic isolated hematuria, but the one point I would like to make about this is that if patients are over 45, about 20% of them will have a urological diagnosis. All patients who are identified to have asymptomatic hematuria should have a urological workup, but if you're over 45, it's much more likely you'll find something in that. Whereas if patients are under 45, it's far more likely that there's a primary renal condition, and this is associated with an increased lifetime risk of end-stage kidney disease, so they should have monitoring. So thank you very much for your attention, and I'd be very happy to take any questions that you might have.
Thanks again, Martina. That was phenomenal, and I appreciate you finishing on time. There are a few questions. One question that someone asked is, which syndrome, nephrotic or non-nephrotic, has the worst prognosis?
Oh, well, I guess that there are so many factors that feed into that. I think so. If you talk about the primary nephrotic syndromes, if I had to pick one, I would choose to have minimal change disease because that has quite a good prognosis. The one I don't want to have is primary FSGS because that's very difficult to treat and can recur post-transplant. So there's such a range of prognosis for each of these conditions that it's very difficult to tell. When you talk about the non-primary podocytopathies and what is proteinuria, which ones are worst, I think to talk in very broad strokes, if you have any condition that causes proteinuria to the level of reaching nephrotic range, unfortunately, that does not have a good prognosis.
Great. Another question: Why do patients with nephritic syndrome have a high JVP?
So they tend to be more volume expanded, and because you've got that, I suppose there are a couple of different explanations for this. They're more volume expanded, they're more salt sensitive, so they're more fluid overloaded because you have injury on the endothelial side as opposed to the epithelial side. There's more endothelial activation and more renin-driven hypertension from the kidney. For those who have a primary podocytopathy and have heavy proteinuria, they tend not to be as hypertensive simply because they don't have the same level of renin-mediated hypertension. They are also a little salt overloaded, but the physiology gets a little complex.
In your case, and this is from the question, I don't remember whether this was what you stated, but assuming it is, the question is, why did the woman in case 1 with a minimal change nephrotic syndrome show hematuria in her urinalysis?
Yeah, and I suppose I threw that in as a little bit of red herring, and simply because there can be some red cells with any of these conditions. You know, we're classically taught that these are completely bland, but a small number of red cells can occur even in these primary nephrotic conditions. So when you are seeing your patients, I would encourage you not to be completely thrown by that. You'll end up biopsying most of these patients anyway, but there is obviously a spectrum.
And I think the other point is that some of these glomerular syndromes, you can get associated thin basement membrane abnormalities with focal thinning of the basement membrane. And some people think of this as a variant of Alport's. It's not actually Alport's, but Alport's and thin basement membrane disease share one characteristic, which is that they have thinning of the basement membrane. The morphology is different. And so patients with membranous, about a third of them, sometimes patients with lupus can get patients with minimal change of disease can get isolated thin basement membrane abnormalities that can make them have hematuria, and that can make managing these patients a bit more complicated because you always think, well, am I missing something? Do you agree with that?
I do. And to your point as well, actually, you know, with primary FSGS, we have a much greater understanding in the last few years as to what causes these conditions. A large proportion of primary FSGS is actually familial, and it's increasingly recognized that a proportion of the familial forms of FSGS actually have collagen basement membrane abnormalities. So those patients may also have some hematuria.
There's a question about the risk of orthostatic proteinuria for the development of nephrotic syndrome, and as you know, people who are younger, teenagers, can sometimes see their doctors, primary care doctors, with orthostatic proteinuria, and they get worked up. And the question really is, how do you manage them? What proportion of these end up with nephrotic syndrome? What proportion of these patients just get better on their own? Any thoughts about that?
Certainly, to my knowledge, that's a very benign condition and really not associated with significant long-term outcomes. I think it is well worth monitoring them and repeating the proteinuria intermittently and certainly watching for hypertension, but the vast majority do extremely well.
And then last question, treatment. You've got patients with nephrotic syndrome or nephritic syndrome, that would probably be easily another hour to go through specific treatments. But can you speak a little bit to general approaches? How do you approach a patient with nephrotic syndrome or approach a patient with nephritic syndrome? Maybe starting off with things like with nephrotic syndrome, thinking about how to manage the coagulation risk and the degree of proteinuria and the edema, and maybe with nephritic syndrome, how you manage the inflammatory process and the renal failure.
Yeah, I think you can sub-classify how you would manage it into many different ways. I think first line for all of these patients is going to be an ACE inhibitor to control their blood pressure, control their proteinuria. When you refer to anticoagulation, that is, I suppose, somewhat controversial, but certainly we would consider anticoagulation in patients with heavy proteinuria whose albumin is under 2 because they are at increased risk of thrombosis. And then in terms of specific therapies for, I suppose, immunological therapies for the different glomerular conditions, steroids have traditionally been used first line really for all of them. There is increasing data that rituximab is useful in many of these glomerular conditions. I think, steroids would be considered first line for minimal change, then cyclosporin or tacro as second line, but there is more observational data that rituximab is useful. We just don't have clinical trials on that yet. For membranous nephropathy, there's been some good data over the last couple of years in the Mentor study showing that first-line rituximab is effective. So I think most of us in clinical practice would use that. Then as we get into the more nephritic syndromes, we have good studies on the management of ANCA vasculitis. Again, we use rituximab for that. In some conditions, in some situations, if patients are particularly unwell with pulmonary hemorrhage and they may be started on cyclophosphamide. Things like IgA nephropathy, unfortunately, we don't have good data as to what works well in IgA nephropathy. There's some data for steroids, but other studies looking at things like MMF have been negative and not shown benefit. So there are, I think one of the heartening things about working in this field is that even within the last 5-10 years, we have a lot more data about how to manage a number of these conditions, and we understand the pathophysiology much better. If you take membranous nephropathy as an example, we now understand that this is an antibody-mediated disease. We have a biomarker that we can follow. The experts in the field, like Fervenza, would suggest that we can follow the titers of antiphospholipase A2 to guide therapy rather than the proteinuria in and of itself. So it becomes a much more targeted approach to management than what we were doing in the past.
Great, thank you. Thanks very much again, and thanks for joining us on a Sunday morning. Appreciate it.
Thank you. Best of luck, everyone.